I'd like to acknowledge the traditional custodians of the land on which I'm recording today and pay my respects to elders past and present. I'm Kate. I'm an Australian pharmacist with more than 25 years of experience working across hospital pharmacy, community pharmacy, palliative care, aged care, and now voluntary assisted dying. Welcome to Pop Pod, the clinician edition of Prescribe or Pass. Look for me on Instagram, TikTok, Facebook, and YouTube at Prescribe or Pass. Every episode explores one medicine, one condition, or one clinical concept, explaining not just what we do, but why we do it. Whether you're a pharmacy student, pharmacist, or any clinician who works with medicines, welcome to the Pop Pod. Welcome back to our series on menopausal hormone therapy. In episode 1, we talked about what happens to our hormones during perimenopause and menopause. In episode 2, we looked at what menopausal hormone therapy can and cannot treat. In this episode, we're meeting the headline act. In our menopausal hormone girl band, Beyoncé is estrogen, Adele is progesterone, and Pink is testosterone. And we will give Adele and Pink their own episodes because each has a distinct role. But this episode belongs to Beyoncé. We're going to talk about what estrogen is, what it does, and the different ways we can deliver it as menopausal hormone therapy. Because Beyoncé can arrive as a patch and a gel or a tablet. The performer may essentially be the same, but the route she takes to the stage can change what happens backstage. It can affect how the medicine is absorbed, how consistently it's delivered, how it interacts with the liver, which risks we need to consider, and, perhaps most importantly, whether it fits into the life of the person using it. So what do we mean by estrogen? Estrogen is not one individual hormone. It's the name of a family of hormones, including estradiol, estrone, and estriol. Estradiol is the predominant and most potent circulating estrogen during the reproductive years, and it is mainly produced by the ovaries. After menopause, when ovarian estradiol production has fallen, estrone becomes the predominant naturally occurring circulating estrogen. Much of it is produced through the conversion of androgens in peripheral tissues, particularly adipose tissue. Estriol is a weaker estrogen and is produced in much larger amounts during pregnancy. Most contemporary systemic MHT products used in Australia contain 17-beta estradiol. This has the same molecular structure as the estradiol made by the human ovaries, which is why it is described as body identical. Importantly, regulated pharmaceutical-grade body-identical estradiol is available in standardized tablets, patches, and gels. A person does not need to use a custom compounded product to receive body-identical estradiol. Some older oral MHT products contain conjugated equine estrogens, which are a mixture of different estrogen compounds originally derived from pregnant mares' urine. These products played a major role in the history of MHT and in many of the large early hormone therapy studies. However, they are not chemically identical to human estradiol, and this distinction matters when we interpret the research. MHT is not a single medicine. Studies may examine different estrogens, different doses, different routes, and different progestogens in different populations. Saying that all MHT has the exact same benefits and risks is a little like reviewing one Beyoncé concert and assuming that every performance, venue, sound system, and supporting act will be identical. What does systemic estrogen treat? Systemic estrogen is the most effective treatment we have for the menopausal vasomotor symptoms, hot flushes and night sweats. It may also help with sleep disturbance when that sleep disturbance is being driven by night sweats or temperature dysregulation. Some people report improvements in joint aches, mood, concentration, or their general sense of well-being. The response varies and symptoms can have more than one cause, so estrogen should not be presented as a cure for every difficulty that occurs in midlife. Systemic MHT also helps prevent the loss of bone that accelerates after menopause and reduce fracture risk whilst it is being used. Estrogen may improve the genitourinary syndrome of menopause, including vaginal dryness, discomfort, and some urinary symptoms. However, someone whose symptoms are confined to the vulva, vagina, or urinary tract may need local vaginal estrogen rather than systemic treatment, or may use local treatment in addition to systemic treatment. That is a different Beyoncé performance. Local vaginal estrogen is intended to work primarily in the vaginal and surrounding tissues with very low systemic absorption at standard doses. A patch, gel, or tablet use for systemic MHT is designed to deliver estrogen throughout the body. Today, we are concentrating mainly on these systemic formulations. But before we compare formulations, it helps to separate three ideas. Beyoncé is the estrogen molecule. The patch, gel, or tablet is the vehicle bringing her to the venue. And the dose is the volume setting on the microphone. Changing from a tablet to a patch does not simply mean turning up or down the volume. It changes the route. Similarly, a larger patch does not necessarily mean better treatment. And one pump of gel cannot automatically be considered equivalent to one pump of another product. Different formulations have their own different delivery characteristics. Published dose conversion tables can provide approximate comparisons, but they are guides rather than guarantees of identical blood concentrations or symptom responses. The correct dose is the lowest dose that adequately manages the person's symptoms whilst considering their age, health, treatment goals, adverse effects, and the need for endometrial protection. Let's start with patches. With an estrogen patch, Beyoncé enters through the stage door and moves into the systemic circulation through the skin. The medicine is delivered gradually across the skin over several days. Oestradiol patches currently used in Australia are changed twice weekly, approximately every 3 to 4 days. Patches are generally applied below the waist, often to the lower abdomen or buttock, on clean, dry, intact skin. They should not be placed on or near the breasts. The person should avoid applying moisturizer, oil, powder, or sunscreen directly under the patch because that can interfere with adhesion. Application sites should be rotated to reduce skin irritation, and a new patch should not be repeatedly placed on the exact same area. The patch needs firm pressure when it's applied, particularly around the edges. Holding it in place with the palm of the hand for several seconds can help the adhesive warm and attach to the skin. People ask whether they can shower, swim, or exercise whilst wearing a patch. Modern patches are designed to remain intact during ordinary daily activities, including showering and exercise. But real life is real life. Sweat, heat, friction, moisturizer, swimming, and differences in skin can all affect adhesion. Some people find patches wonderfully convenient. They apply one, change it on the scheduled day, and barely think about it in between. Other people find that the corners lift, the patch irritates their skin, attracts fluff around the edges, or falls off during exercise. Neither experience means that the patch is inherently excellent or inherently terrible. It means the delivery system needs to suit the person. If a patch falls off, the product-specific instructions should be followed. Depending on the formulation and circumstances, a replacement patch may need to be applied. People should not stick on multiple patches to catch up. A diary, phone reminder, or occasion with regular days, such as Mondays and Thursdays, can help with twice-weekly products. One advantage of a patch is that it provides relatively steady delivery. There is no daily tablet to remember and no gel that needs to dry before getting dressed. Another major advantage is that transdermal estrogen avoids first-pass metabolism through the liver. That distinction is clinically important. Gels. Estrogen gels are also transdermal formulations, so Beyoncé is still entering through the skin and avoiding the initial journey through the gastrointestinal tract and liver. But instead of arriving in a patch that releases her over several days, she's applied to the skin, usually every day. The exact application area and technique depend on the product. A gel may be applied to the outer arm, thigh, or other approved area. This is not a situation where more surface area or more vigorous rubbing necessarily improves absorption. The person should follow the instructions for that specific product. The skin should be clean, dry, and unbroken. The gel is spread in a thin layer and allowed to dry before clothing covers the area. Hands need to be washed afterwards. The application site should not be washed too soon, and other skincare products should not be placed over it unless the timing is consistent with the manufacturer's advice. One practical issue is transfer. While the gel is drying, and potentially for a short period afterwards, the application area should not come into contact with other people. That includes children, partners, and pets. Once the product has dried, the area can be covered with clothing, but people should follow the specific instructions supplied with their formulation. Gels can be very useful when someone wants transdermal treatment but cannot tolerate patch adhesives. They can also allow flexible dose adjustment. On the other hand, they require a daily routine. Someone must remember to apply the prescribed amount, allow it to dry, and avoid accidentally washing it off too soon. For a person who showers at irregular times, swims every morning, cares for small children, or simply dislikes the sensation of gel on the skin, this may be inconvenient. There can also be variation in absorption between individuals. Skin characteristics, application technique, and consistency may all influence the amount absorbed. That does not make gels unreliable, but it does make correct, consistent use important. Changing from one gel to another product is not necessarily a straight pump-for-pump substitution. The concentration and amount delivered per pump can differ. And this is a good reminder for pharmacists to slow down. Do not assume that one pump is a universal unit of estrogen. Check the prescribed product, its concentration, the prescribed number of measures or pumps, and the manufacturer's instructions. Estrogen tablets. With an oral estrogen tablet, Beyoncé comes through the front entrance. She travels through the gastrointestinal tract, is absorbed, and then passes through the liver before reaching the wider systemic circulation. And this is called first-pass metabolism. That liver journey is not automatically harmful. Oral MHT remains a reasonable option for many appropriately selected people. But the route changes some of estrogen's effects. Oral estrogen stimulates the liver to alter the production of various proteins, including clotting factors, binding proteins, and inflammatory or metabolic markers. This is why oral and transdermal estrogen cannot be treated as pharmacologically identical simply because they are both called estrogen. The oral route is associated with a greater risk of venous thromboembolism than transdermal estrogen. For an individual younger than 60 without major risk factors, the absolute risk may still be very low, but risk is not distributed evenly across the population. Age, obesity, smoking, and personal or family history of thrombosis, thrombophilia, cancer, major surgery, prolonged immobility, and other medical conditions can all change the baseline risk. The Australian Menopause Society advises that oral MHT increases VTE risk and that transdermal MHT is preferred for women at increased thromboembolic risk. The Society states that transdermal MHT does not appear to increase VTE risk above baseline in the same way as oral therapy. International guidance similarly advises considering transdermal oestradiol as the first choice route when VTE or cardiovascular risk factors are present. Oral estrogen can also increase triglyceride concentrations in some people, whereas transdermal estrogen has less effect on hepatic triglyceride production. For someone with significantly elevated triglycerides, metabolic concerns, or an increased clotting risk, the route of administration deserves particular attention. Transdermal estrogen is also often preferred in migraine, especially migraine with aura, because it generally produces steadier estrogen exposure and avoids some hepatic effects. This still requires individual assessment. MHT is not the same as the combined oral contraceptive pill, but neither should it be prescribed without considering the person's vascular risk factors. Why then might someone still choose a tablet? Because tablets are familiar, discreet, and easy for many people to take. There is no adhesive, no visible patch, no drying time, and no risk of gel transfer. Some people prefer adding a tablet to an established medication routine rather than remembering a patch change schedule or daily skin application. For a suitable, low-risk individual who understands the options, an oral formulation may be a perfectly reasonable choice. The aim is not to announce that tablets are bad and patches are good. The aim is to understand that they take different routes to get to the stage. Is transdermal always better? Transdermal estrogen is increasingly used because of its favourable effects on clotting and liver-related markers. However, preferred in many situations does not mean universally best for every person. A patch is not better if the person develops significant dermatitis, cannot keep it attached, or repeatedly forgets to change it. A gel isn't better if it's applied inconsistently or washed away shortly after application. A tablet is not automatically inappropriate for every healthy person in their 40s and 50s. Good prescribing involves matching the formulation to the person's clinical risks, preferences, dexterity, routines, skin, other medicines, financial circumstances, and access to supply. It is also important not to assume that a symptom flare automatically means the dose is too low. If symptoms recur, first ask some basic questions. Is the medicine being used consistently? Has the patch lifted or been exposed to unusual heat? Has the gel application routine changed? Was the product switched? Is there a supply issue? Has a new medication been introduced? Could the symptom have another explanation? Dose escalation should not become a reflex response to every bad week. Perimenopause is particularly variable because endogenous ovarian activity has not necessarily stopped. A person may be using a stable MHT dose while their own hormone production continues to fluctuate underneath it. Beyoncé may be performing consistently, but the rest of the venue can still be unpredictable. What about blood tests? Routine serum estradiol measurements are not usually required to prescribe or adjust standard MHT in otherwise typical circumstances. Treatment is generally guided by symptom response, tolerability, bleeding patterns, clinical risk, and adherence rather than by chasing a particular laboratory number. A blood concentration represents one point in time and may be difficult to interpret, especially during perimenopause when endogenous hormone production fluctuates. Levels can also vary according to the formulation, application timing, and laboratory method. There are several clinical situations in which testing may be useful, but routine testing should not replace listening to the patient and assessing the actual clinical response. We are treating a person, not trying to make Beyoncé reach an arbitrary position on a laboratory chart. And Beyoncé cannot always perform alone. Now we need Adele. If someone has had a hysterectomy and no longer has a uterus, they can use estrogen without progestogen. But when the uterus is present, systemic estrogen stimulates the endometrium, the lining of the uterus. Unopposed stimulation over time can cause endometrial hyperplasia and increase the risk of endometrial cancer. This is why adequate progesterone is required alongside systemic estrogen for someone who still has a uterus. In our girl band, Beyoncé may be the headline act, but Adele provides essential protection backstage. This protection may be delivered using oral micronized progesterone, another progestogen formula, or in appropriate cases, a levonorgestrel intrauterine device. The regimen may be cyclical or continuous depending on factors including the person's menopausal age, bleeding patterns, and treatment plan. We will cover Adele properly in the next episode. For today, the key message is simple. Do not assess the estrogen dose without also checking whether endometrial protection is appropriate and adequate. This becomes especially important when higher estrogen doses are used. The Australian Menopause Society notes that evidence is insufficient to be certain that standard micronized progesterone regimens provide adequate protection with all higher estrogen doses. Unscheduled bleeding may also become more likely. Higher is not automatically better, and estrogen should not be escalated indefinitely without reviewing the entire MHT regimen. Side effects and early expectations. When systemic estrogen is started, possible adverse effects include breast tenderness, bloating, nausea, headaches, and fluid retention. Some people notice temporary symptoms whilst their body adjusts. Others may need a lower dose or a different route. Bleeding is more closely related to the entire regimen, including the progestogen and whether therapy is cyclical or continuous, than to estrogen alone. New, persistent, or unexpected bleeding should not simply be dismissed as normal because you are on hormones. The timing, pattern, duration, age, treatment regimen, and individual risk factors all matter. Bleeding may require assessment according to current clinical guidance. People should also understand the symptoms that need urgent medical attention, including possible symptoms of a blood clot, stroke, or other acute illness. MHT reviews should consider symptom control, adverse effects, bleeding, blood pressure, relevant cardiovascular and thrombotic risks, breast and cervical screening where appropriate, medication adherence, and whether the chosen formula still suits the patient. There is no universal date on which everybody must stop MHT. Treatment should be individualized and periodically reviewed rather than continued automatically or stopped solely because someone has reached a particular birthday. The pharmacist's role. Pharmacists can make an enormous difference here. We can check that the patient understands which product they've received, where it should be applied, how often it should be changed or used, and what to do if a dose is missed. We can explain that gels need time to dry and must be used in the way that minimizes transfer. We can identify when a brand substitution has unintentionally changed the dose or application instructions. We can ask whether a patient with uterus has also been prescribed appropriate endometrial protection. And we can help patients understand that changing routes does not mean they have been moved to a stronger, weaker, or more serious treatment. It may simply reflect risk, availability, adverse effects, or preference. Good counselling turns a box of hormones into a treatment that the person can actually use safely. So bringing it all together, what have we learned? Beyoncé is estrogen, but estrogen is not one single formulation. Most contemporary systemic MHT uses body-identical oestradiol, delivered as a patch, gel, or tablet. Patches and gels deliver estrogen through the skin and avoid first-pass metabolism through the liver. Tablets pass through the gastrointestinal tract and liver before entering the wider circulation. That hepatic first pass helps explain why oral estrogen has a greater effect on clotting factors and is associated with a higher risk of venous thromboembolism than transdermal estrogen. For many healthy, symptomatic people younger than 60 or within 10 years of menopause, the overall benefit-risk profile of appropriately prescribed MHT is favourable. Transdermal routes and lower doses may further reduce the risks of venous thromboembolism and stroke. But the best formulation is not determined by a slogan. It's the one that provides adequate symptom control as an appropriate dose, fits the person's risk profile, and can be correctly and consistently used. Beyoncé may be arriving through the stage door, through the front entrance, or in a completely different vehicle. She may perform through a patch changed twice a week, a gel applied, or a tablet swallowed each morning. The goal is not to declare one entrance morally superior. The goal is to get the right performer through the right entrance at the right volume for the right person. And if that person still has a uterus, we need to make sure a DEL is not accidentally left off the tour. Some reflective questions. How confident am I in explaining the clinical differences between oral and transdermal estrogen? When counselling a patient, do I clearly distinguish between the estrogen molecule, the dose, and the route of administration? Which patient factors would make me more likely to recommend or discuss a transdermal rather than oral estrogen? Could I explain why oral estrogen has a greater effect on hepatic proteins and venous thromboembolism risk? What practical counselling points would I provide for an oestradiol patch, including application site, adhesion, rotation, and what to do if it falls off? What practical counselling points would I provide for an oestradiol gel, including drying time, washing, consistency of application, and transfer to other people? Do I routinely check the exact strength, formulation, and application instructions when a patient changes brands or delivery system? How would I respond if a patient said that a patch was stronger or more natural than a tablet? When a patient reports that their symptoms have returned, do I first assess adherence, application technique, formulation changes, and alternative causes before assuming the dose is too low? Do I remember to check whether a patient using systemic estrogen still has a uterus and, therefore, requires adequate endometrial protection? How confident am I in explaining that regulated body-identical estradiol is available in standard pharmaceutical products and is not limited to compounded prescriptions? What gaps in my knowledge about estrogen formulations, dosing, or counselling would I like to address after listening to this episode? In the next episode, we will turn our attention to Adele, progesterone, and the progestogens. We will look at why they are needed, how the different formulations compare, why they can influence bleeding and adverse effects, and why the supporting act is actually performing one of the most important safety roles in the entire show.